For this next session of the Future of the American Child journalism training, we're going to talk about the impact of COVID on child health. It's affected so many aspects of our lives that it's really important to understand how one of the most vulnerable groups survived and got through the COVID pandemic. But we're very fortunate to have two researchers who will not only help us understand that specific angle, but they'll also be able to help us tease out how the research, how what we've learned from COVID will help any of us in our coverage of child health. We're joined today by Dr. Amy Edwards and Dr. David Miller. They're both researchers in the Division of Pediatric Infectious Disease at University Hospital's Rainbow Babies and Children's Hospital. Dr. Miller will go first, followed by Dr. Edwards, and then we'll open up the discussion. And I encourage you to take advantage of having researchers from one of only about 12 research centers in the entire nation that are focusing on the impact of long COVID on children. So, Dr. Miller.
There we go. Good. And I'm actually an integrative medical physician, and Dr. Edwards and I are co-directing the Pediatric Long COVID Recovery Clinic at Rainbow. And so thank you guys for being here. Thank you for your interest in this. Today we wanted to help you understand more about what long COVID is. And as we talk about this, we've very much had in mind sort of what kinds of stories would be meaningful and useful. And at the end of this, we put together some ideas we thought might be inspirational for different ways to go with reporting on this as well. So we want you to recognize the prevalence and impact of long COVID in the pediatric population specifically. You hear a lot about adult long COVID, very little about pediatric long COVID, and that's one of our big messages for today. We need more reporting on pediatrics. Identify the most common presenting complaints and how to identify individuals who may have long COVID, and understand gaps in our understanding on long COVID, and how to maybe use this to use targeted storytelling to expand that knowledge base for everybody. So there's a lot of different names for long COVID. You'll see long COVID, long haulers, COVID long haul, PASC, post-acute sequelae of COVID-19. By and large, long COVID or long haulers are the most common kinds of terms, but they all mean the same thing. In more scientific presentations, you're going to see PASC, but patients by and large don't care for that designation because it doesn't make any sense to them and it sounds really weird. And that's about it. So what is long COVID? I mean, I think one of the biggest points about this is that long COVID is not a single thing. It's a syndrome. It is a phenomenon that occurs with multiple presenting signs of disruption in an individual. So you identify these individuals when they present with a cluster of symptoms that are in close approximation to a known or suspected case of long COVID. And these can be very mild or they can be quite severe as well too. So really long COVID is a symptom cluster developing shortly or after persisting. So not just one thing. And that's a really important thing to understand too, because it makes it much harder to diagnose. It makes it much harder for people to explain what's going on with them. And it makes the patients feel like they're relatively crazy. We did a symptom review of our first 60 patients at Rainbow. And I know that's a little hard to read. I know you'll get these slides as well though. And fatigue is by and large our number one symptom, as well as what's called post-exertional malaise, where people exert themselves and then they have a crash thereafter. And so that's one of the characteristic signs of long COVID. Also, when you have that post-exertional malaise, where they would do something they wouldn't normally do, and then all of a sudden can't do things for sometimes 2 or 3 days. But you'll see kids who normally were athletes and active and in school, and they'll come home after school now and they will sleep for 4 hours, and then they'll get up and maybe they'll go to bed, or maybe they'll just completely disrupt their own sleep cycles. But quite devastating. And so you'll see these clusters of symptoms. So I'm not going to do a formal case this morning, but this is a case patient that we had come in who presented with actually 14 different symptoms at the same time. And she was seen by multiple providers, mostly in gastroenterology actually to start with. So her main complaint was abdominal pain. And so she got sort of the $1 million workup for abdominal pain with scopes and MRIs and CT scans and blood tests and stool tests and all these kinds of things, but no one really asked about her full constellation of symptoms. So when she came in just for an integrative medicine consult, actually, just to try to figure out what was going on, I started asking questions, and it turns out she has fatigue, she has post-exertional malaise, she also had headache and dizziness and loss of appetite and anxiety, and she had ultimately 14 different symptoms. And so it's sort of like, okay, you don't just have abdominal pain, you have a long COVID syndrome that we need to deal with. And so these kids are super complex. They take a lot of work. We need resources to treat them. And I think this is another interesting story we'd love to have help with is that we can't get paid really to treat these kids. Like we can bill insurance, right? But I spent like 4 hours the other day with one kid and I can't bill insurance like for 4 hours at a time. It's not going to pay. Or on the other hand, if I were to bill that amount of time, the family could get a catastrophically large medical bill that they're like, oh my gosh, what's going on? And we see that as well too, that these families have huge financial burdens that are placed on them by this syndrome that disrupt life dramatically. I have a family I'm going to meet again today, this afternoon, because the 2 hours on last Monday wasn't enough. They moved to a farmhouse because their child has become so sensory sensitive. They wanted to take him out of a city environment to see if he could recover. So they've literally like rented a house in the country to take him to, and this is not a wealthy family. We have another family that's down in Arkansas right now at a 4-month or 3-month program that's $100,000 that they're doing, and they had to hold fundraisers to bring this kid down there to help get control mostly for like pain syndromes, but he also has something called non-epileptic seizures, which have been really intrusive for him and for the family as well too. So we also need investment in interprofessional communications. There's been very few like meetings about this. This was the one meeting. This would be an interesting thing to look into. The National Long COVID Conference occurred on October 3rd, 2022, last year in DC, which is a great meeting, brought people in together all around the country, but it was the first meeting and the last meeting we've had that was a coordinated sort of long COVID professional meeting. So we really need more of these kinds of things too, as well as primary clinical care and helping primary medical doctors understand what's going on. So, multiple symptoms create complexity, and this is a challenge because it's beyond the skills of virtually all individual doctors, ourselves included, right? A kid comes in, and imagine you're a primary care person coming in. I know that's not your, but you can imagine. And a kid comes in and like, oh, I have fatigue. And like, oh, okay, fatigue, like a little, you're tired. Like, no, I can't go to school. Like, I can't get up. I can't do my sports. I have a raging headache. I'm incredibly anxious. My digestive system's a mess. I've been constipated for 2 weeks, and the doctor's just going to be like, I have 10 minutes with you, maybe 20. What are we going to do about that? Plus, I don't know how to manage your fainting in the shower. I don't know how to manage, the fact that, you can't eat, for example, too. So it gets really, really complex that way. And so I think just helping people understand also how this presents. So as doing a story to talk about these kids who are coming in with all these different complaints, who often get missed, who often get shuttled from specialist to specialist, is a really important kind of conversation to be having. So we say this is sort of the quintessential integrative medical condition because it disrupts all activities of life. We've spent a lot of time on the phone and in Zoom meetings and with letters to schools, particularly too, who are trying to understand what's going on with their kids and how do they help these kids. I think some of the schools have been phenomenal and some have been horrific in terms of how they manage these kids. I spoke to 2 really nice principals last week who really want to help their kids, but they need letters, they need support, they don't know how to get them through. Their schools may be private, they don't offer like virtual schooling, like how to get these kids through the school year so they don't fall behind and like disrupt their whole academic progress for years to come. It's really hard to know. But we use conventional medicine, we use dietary supplements, we use mind-body interventions, a lot of sleep management, and strategies like pacing, which come out of the chronic fatigue literature. So patient appearance, extremely complex. These patients present, they think they're crazy. A lot of times other people think they're crazy too. They get very variable treatment in the emergency rooms. This was a quote, unfortunately, from one of our families. Neither doctor seemed to know what long COVID was. One asked us if it means you cough a lot, literally no idea what it is. They said they'd never heard of it. That was disturbing, as it was. And so we're sympathetic too to the complexity of this in the ER, but at the same time, you've got to be able to recognize these kids and you've got to have some idea of what to do with them. And we're sort of working to educate and struggling to do that, but that's a big battle. And there's just a million really compelling patient stories to be told. And exploration into where do doctors stand in their beliefs around long COVID. I was doing some looking into this to see what was out there. And there's actually a formal kind of research article on long COVID and medical gaslighting, dismissal, delayed diagnosis, and deferred treatment. And The Guardian actually has done quite a big series on people not believing people with COVID and have a lot of patient stories. What I would say is in looking at these, they're all adults. No one is telling the pediatric story at all. So there's 1,000, 10,000, 100,000 pediatric stories that are really moving and dramatic and important that have not been told. And I would be really curious to know as well too, talking to some doctors who still don't believe this is a thing or don't really want to believe the kids, like it's just anxiety, they're just stressed from the pandemic. It's like, tell me more about why you're in that place and how do we get you out of it? Because it's a really problematic place for doctors to be. So that could be a very interesting approach. So the symptoms have to have lasted at least 4 to 12 weeks after an infection. And I put the generally occurs in highlight here too. So in October of 2021, the World Health Organization proposed a clinical definition based on what's called a Delphi consensus statement, saying it generally occurs 3 months. But I just emphasize today that this is a work in progress. There's an active call for comments from the National Academies of Science and Engineering on trying to get a better definition of long COVID. Dr. Edwards was just telling me there's a 2-hour webinar today on this topic, and they've had a couple of different sessions on it. That would be a really interesting thing to explore. But even the definition of long COVID is a work in progress. And if I can, Dr. Edwards was just telling me too, as we listen to these conversations among people trying to do things like define long COVID, they're talking like, oh, you have COPD and you get COVID, right? And then this happens. Or you have end-stage heart disease and you get COVID and this happens. Like, well, what about when you're 11 and you're great, right? And you're an athlete and you're an A student and you get COVID and you can't play sports and you start failing out of school and you can't do any of these things and no one believes you. Like, what do you do in those situations? So we need those definitions to include kids and to be sure they capture our population as well. So there's a lot of patient concerns that go along with their experience. Isolation is massive. They all think they're the only one. So we're still trying to work to set up like groups where they can meet together and talk about their experiences, because literally, you know, unfortunately, they lack perspective at that age. We're seeing kids that are mostly between the ages of 11 and 21. And especially the younger kids just don't understand. They just think they're the only person who's ever experienced this. School accommodations are super challenging. Social disruption is profound. We worry about suicidality a lot. One family that came to us basically said, you know, you may not realize it, but you saved my son's life because we thought he was going to just do himself in because he didn't know what was going on. He thought he was going crazy. And so, you know, that's a real issue, not to mention just the depression from disruption to who they were and who they're not sure they'll be again. And we're optimistic that most of them will recover, but we don't honestly know how many will because the whole thing's been around for 2 years, right? So we don't know the long-term outcomes on long COVID in these kids. Failure being disbelieved, the medical system not recognize the condition, and things like dating and things like that. We have some people who are now in their early 20s. They have, you know, partners and things like that. So what's that experience like? How do you find someone who'll put up with you when you can't get out of bed like many days of the week, or you crash with any exertion? And writing a lot of letters now too for college. Like, these kids should not be in rooms with 6 other people, like as dorm settings. You know, they one of their management strategies that we use really intensely is sleep hygiene. They need really restorative sleep, and they need to be able to do what's called pacing, where they take preemptive rest. So they rest before they're tired, and they need a space to be able to do this. And if they're sharing these big rooms, they can't do it. If they don't have access to cooking, sometimes that's a really big problem because the school cafeterias won't have foods that are optimal for them, because we find that simple carbohydrates like just sugar, but also like white bread, white pasta, white rice, all those things flares them. And so they need really healthy diets if they're willing, which many of them are. And that can make a profound difference, but they've got to be able to get that at college too. So really a lot of stories to be told there. Sorry, I jumped one. And so with that, I'm actually going to transfer over to Dr. Edwards and let her continue.
All right, so I have the easy job of digging into the science of long COVID, and the pattern of the next 10 or 20 minutes is going to be, I don't know, or we don't know, but we will talk about what we do know, what we suspect, and what research still needs to be done. So as we've talked about, we know it's very clear that adults and children are impacted by long COVID. What we don't know is what the mechanism is. What is the virus doing to our bodies that is causing some percent of the population to not recover? We have our suspicions, and this paper essentially outlines kind of the biggest guesses, I guess is what you could say. So what we see is several different hypotheses, including immune dysregulation. So this is the idea that you get COVID, your body fights it off, but it doesn't completely fight it off, and then COVID is still hiding somewhere in your body. And that it can periodically or constantly reactivate either in some tissue spaces or in all the tissue spaces. disruption of the gut microbiome. So we actually already know from MIS-C, multi-system inflammatory syndrome in children associated with COVID-19, research in that post-COVID syndrome has shown that the virus can continue to replicate in the guts of children even after their acute COVID is done. And in fact, we think that's one of the mechanisms that triggers this inflammatory syndrome that they get about 4 to 6 weeks after their COVID infection. And the question is, what does that ongoing viral replication in the gut do to the gut microbiome? What does it do to their immune system through the gut microbiome? You might think that these two things aren't related, but actually the GI tract and your immune system are BFFs. And the GI system is the largest chunk of organ that's involved in immune regulation. And the gut microbiome plays a huge role in our immune system. And so these two are very much interrelated. Actually, all of these are interrelated, and we'll continue to talk about that. So another possible pathogenesis is the idea of like autoimmunity or immune system priming. So before we're all born, our immune system learns what we are and what other is. Our immune system makes a very clear distinction between us and them, and it's designed not to fight us and to fight all of them. That doesn't work so well in women because those of us who choose to bear children have to not kill them. And so we know that women are at increased risk for autoimmune disease because our bodies are a little different. But we also know that there's certain infections that can create immune priming. So for instance, we know that with measles infections can affect the way B cells function afterwards. HIV can affect the way T cells function. So this idea that viruses and bacteria can interact with our immune system and change the way it functions is actually old news in the infectious disease world. And it's something that really we already know that COVID is capable of doing. There's already some autoantibodies that have been discovered after COVID infection. And is there a role for this in long COVID? And we still don't know. And then blood clotting, and we're not talking about big clots like you see in CT scan and things like that. We're talking about microclotting that you generally can only see in a pathology slide under a microscope. And we do know that this happens in patients with long COVID. We had a girl with severe problems with her GI tract. We got the scope, we got the biopsies, and she had microclots all throughout. But is that a symptom of long COVID or is it a cause of long COVID, right? And we don't know. And the other thing is coming back to immune dysregulation and disruption of your gut microbiome, which can cause a lot of inflammation. We know that inflammation can cause clotting. So again, how much of this is one, how much of it is are they linked in? And then the last is dysfunctional neurologic signaling. We already know that COVID can disrupt the olfactory nerve. That's why we get anosmia after a COVID infection. We just recently discovered about a month and a half ago that COVID can disrupt the phrenic nerve, which is the nerve responsible for moving your diaphragm when you breathe. So it turns out all those people who were complaining of shortness of breath but had normal pulmonary function testing probably actually did have shortness of breath because their diaphragm was weak because their phrenic nerve was damaged. So in light of the fact that we know that COVID can damage some of our nerves, we now have to come up with, like, is it possible that it's damaging more nerves than we realized? Which again, our nervous system is very sensitive to inflammation. So it brings us back to some of these other possible mechanisms. So if you want my personal opinion, I think it's all or some of these. And I think it's probably different combinations in different people, which is why we have slightly different manifestations in different people. But what we need now is the science to prove this. And we're a long way from that. But we do have some clues here and there that have been coming out in the last 4 to 6 months, starting to point towards these mechanisms. And it is freezing in here. Can I just I don't know how you guys have been staying here all morning. So then the next question, how common is it? And the next answer is, I don't know. And really nobody does. And part of the reason Dr. Miller had already talked about how we're only now working to define what long COVID is, and we're having a really difficult time coming up with a definition. As he mentioned, I'm going to be in a 2.5-hour meeting tonight with other physicians to contribute our thoughts to what the definition might be with the National Academies of Science. And because of poor definitions, all the studies that have been done looking at incidence of long COVID are just all over the place. You'll see some that come out with an incidence of 2%, and then some that will come out with an incidence of 75%. And when you see numbers that are that wide apart, you know that we have no idea. I mean, there's no way two different populations can have incidence that's far apart. That doesn't even make sense. If they were all in the 20 to 30% range, you could say, okay, we're at least hitting somewhere near each other, so we're probably looking at the number or at the near number. But no, we have absolutely no idea. The other problem is, especially with some of the early studies and when testing wasn't universally available, they defined the control group as anybody who was COVID negative at the time of the study. Well, let's just think for a minute how good that definition is, because especially in pediatrics, most of the kids weren't being tested. Most of the kids were asymptomatic. We know that even antibody testing is not great in kids. It doesn't perform very well. And we have a lot of kids who are PCR positive, and just out of curiosity, we would run antibody tests and they are antibody negative. So we know they had COVID because they were PCR positive, but we can't prove that they had COVID because their blood work doesn't show it. And so the current testing that we have for COVID doesn't perform very well in kids. And the testing back in 2020 was very much not performing well in anybody. And so using COVID negative people as your control group is problematic. And especially now, we think, let's make better control groups. How? Everybody's had COVID by now. I mean, I haven't, but most people have. And so it's really, really difficult to define a control population. And so it's really difficult to define a study population. So because of that, it's really hard to know how many people have long COVID. Our best guess is in adults, where we have the most data. So if you smush together all the studies, you can come up with sort of an idea of what we might be talking about. So in adults, if you have not been hospitalized, your risk for long COVID is probably somewhere between 10 and 30%. We think it's probably in the 25% range. If you've been hospitalized, your risk is much higher, probably in the 50 to 70% range. And most adult clinicians will cite probably around 60 to 70%. And if you've been vaccinated, your risk for long COVID is probably in the 10% range. And we're gonna come back to this hospitalization because this speaks to the difference between adults and kids, and we'll come to that in a bit. So what role does the vaccine play in long COVID? Well, I just mentioned that we know that the vaccine, at least in adults, it is very clear through multiple studies that the vaccine reduces your risk for long COVID. But what role does the vaccine play in treating long COVID? Well, the answer is we don't know, but anecdotally, what we can report, at least in adults, is that there is some benefit to being vaccinated even after you've had long COVID. There are even reports of people with anosmia who can't smell, who get vaccinated and suddenly their sense of smell returns. That does speak to the immune system, right? The vaccines change your immune system, and so it is possible that immune dysregulation is playing a role, and that's why giving the vaccine helps. Also, residual virus in the body, right? Because then if you vaccinate, then that might wake the immune system up and kill off that residual virus. So there is something there. However, we also know that about 10 to 15% of unlucky individuals getting vaccinated will actually make your long COVID worse. And we don't know why. And we as of yet have not figured out the pattern there. Why is it that some people get worse with the vaccine and some people get better? And then why is it that there's a chunk of 20 or 30% who have absolutely zero response to the vaccine? It doesn't make them better or worse. We don't know. My guess is, again, going back to those different mechanisms that are playing a role in the symptoms of long COVID, is certain phenotypes that have certain mechanisms to their long COVID do respond to the vaccine and certain ones don't. So we need to work to get those definitions so that we can know who to recommend the vaccine to and who needs to avoid the vaccine. So who gets long COVID? Guess the answer. We don't know. So in an attempt to define who is getting long COVID, we took a look at our first 60 patients. We know from adult data that there is a preponderance of females who get long COVID in the adult population. This speaks to maybe some of that autoimmunity playing a role, right? Because we know autoimmune disease is more common in women. Except in our clinic, it's about 50-50, 53% female, 47% male. And then we found in our clinic that 82% of our first 60 patients were Caucasian. And you might think, well, I mean, that's okay. Ohio's a pretty white state, except that if you look at the demographics of Cuyahoga County, which is the county that we're sitting in right now, and compare the demographics of the county in yellow to our clinic in blue, you can see that that's not right. We're missing something. We are way overrepresenting white in our clinic and way underrepresenting both Black and Latino compared to the demographics of this county. Now, one interesting thing is you'll note that we have 0 Asian patients in our long COVID clinic, and that actually holds true with the literature coming out of Asia, particularly China, Japan, and Taiwan, that we're not seeing a lot of long COVID in the Asian population. So there does appear to be a genetic aspect to long COVID, and we think that there is, we all know that there's certain alleles in our genotype that are more commonly expressed in some races than others. And so there is probably a genetic risk that luckily does not run, in Asian races, but we don't know what that is yet. And so this overrepresentation of white is very concerning to me, especially if you look at something recently released by US News and World Report, looking at the percent of people who are experiencing long COVID by race in adults, and you will see that their racial breakdown is much more even. 28% of people who are Hispanic and Latino, 26% of people who are Black, 26. So you can see that it's much more evenly distributed. And there are adults who are Asian who get long COVID. So we clearly in our clinic are missing huge chunks of the population. And that's concerning because we're one of the biggest clinics who do long COVID in kids in the country or in the world, really. And if we're missing patients in our clinic, then that worries me, I guess is probably the best way to say that. The mean age at first diagnosis of their first COVID infection for our population is 13.4, which is in line with all the other studies that have been done in the pediatric population. And 75% of our kids are reporting some disruption to either school or after school activities, including sports and after school clubs. This is very concerning for anybody in the room who's a pediatrician, which I am. Think back to your teen years when you were 12, 13, 14, 15, 18, 19. These are some of the most formative years of your life. These years kind of define who you are and what your future is going to be. Now imagine if those years were spent in bed with chronic illness from an infection. These kids are missing out on prom. They're missing out on school sports. I've got at least 2 scholarship athletes in college who now have long COVID who are worried about losing their college scholarships. These are kids who are now missing out on, after school, I don't know, what are the clubs that are so popular right now? Music clubs or I don't know what. They're missing these activities because they're too busy being sick and dizzy and tired. And if they do try to push to do these activities, so let's say they go to school on Monday, go to soccer practice Monday afternoon, they will crash and spend the next 2 days in bed because they spent all their energy for their week on that one day and then they're done. And so then they miss 2 days of school and then the school is angry because they missed 2 days of school and they did that last week too. And the school wants them back and the truancy officers are calling and Child Protective Services is getting involved because they've missed too many days of school. So the parents are having to pull the kids out of school and put them in homeschooling. So then the parents are having to quit their jobs and you can see what the problem is, right? Let's see if I can make the slide things. There we go. Oh, that, okay. Did you throw this in?
Oh, I guess I did. Sorry.
That's
You don't
okay.
have, that's already.
So this is basically, again, I just emphasizing the demographic problems that we're dealing with. So what we have here is the state of Ohio in yellow, Cuyahoga County in blue, the Ohio Department of Health reporting based on race for COVID-19 infections, and then who we're seeing in our clinic. So you can see that it's all skewed wrong. And we can tell you anecdotally that we are primarily seeing rich white people who are high achieving kids. So we are seeing the straight A students, the scholarship athletes, the team captains, because it's obvious. And their parents, because they're wealthy, are home and can pay it and can see what's going on with their kids, right? So these are the kids that we're seeing in clinic. What about the kids who are medium achievers? What about the kids who are already low achievers? Do you think anybody's going to notice when they miss 3 days of school that week, right? What about the kids who live in a single parent household whose mom has to work 2 jobs? Do you think she's home enough to notice that her kid is suddenly skipping, until the truancy officer arrives and tells her that her kid is staying home and sleeping all day? She might not even notice because she's working 18 hours a day. And so we can tell you that it's the rich white kids who are making it to our clinic, and that's a problem. Oops. And this is another problem. So these kids are coming, Dr. Miller already mentioned, these kids are coming with just this vast number of symptoms, and the pediatricians and all the specialists that they're seeing to try to figure out what's wrong with them are doing these massive workups that's costing tons of money. I've got parents who literally had to stop doing physical therapy, which we had recommended because they couldn't pay for it anymore. We have parents who, because we're the only COVID recovery clinic, we are out of network for them. So they're having to pay out of pocket after some magic deductible is met. And they literally cannot afford the care that their kids need, because these are previously healthy kids. And they're coming in, for instance, let's take an example of a massively overwhelming headache. Well, you can't just say, okay, that's long COVID and not look for the blood clot in the brain because they did have COVID and COVID causes blood clotting. You can't just say, for the kids who are coming in with chest pain, we can't just say, oh, this is long COVID because we know that COVID causes myocarditis. In fact, COVID is one of the most common causes of myocarditis now, and myocarditis causes tremendous amounts of chest pain. So we have to do that EKG and echo to make sure that it's just long COVID and not also myocarditis from COVID. And so the workup that these kids end up needing is huge. It's expensive, and it's not well covered by insurance. This is something that I want to really bring out. We were talking about the fact that we're trying to reach a consensus definition for long COVID. The problem is that the adults have a different kind of long COVID than the kids do. So the adults are getting organ damage from COVID. So they're getting pulmonary fibrosis, they're getting heart failure, they're getting pancreatic failure, they're getting, you name it, that organ is getting damaged. The kids aren't. We're not seeing organ damage from COVID in kids. So all of this, stroke, heart failure, pulmonary fibrosis, pulmonary embolism, that is in the long COVID definition for most adult clinics is not even useful for kids, because they're not seeing any of it. And in fact, the National Academies of Science, the group that I'm meeting with this afternoon, their definition of long COVID is symptoms persisting more than 3 months after an acute COVID infection that increases your risk for illness or death. Because in adults, it does. In kids, it doesn't. So by very definition that the National Academies of Science is setting for long COVID, they are excluding everybody under the age of 25. Right there, leaving all the pediatric population out. Where we do overlap with adults is a lot of that chronic fatigue picture that we talked about, chronic fatigue syndrome, the dysautonomia, their autonomic nervous system isn't working. But what we're not seeing are the risks that the breakthrough infections are having. So when adults get a breakthrough infection with COVID, again, the increased risk of stroke, the increased risk of heart disease. If the vaccine doesn't work for adults, there is risk to health, not in kids. So you can't take adult science and adult medicine and just translate it to children, because kids are not little adults. They are their own separate species, completely different from adults. And that's something that we pound into the head of every pediatrician when they come through training, and not just for COVID, for anything. Kids are not little adults. So this is one of the most common symptom clusters that we see in long COVID, both on the adult and pediatric side. And this, we think, is the crux of the matter, if you will, and that is the autonomic nervous system. So the autonomic nervous system is the part of the nervous system that is responsible for all the things that you don't do. So for instance, you don't tell your heart to beat. Thank goodness, right? Because half of us would forget and we'd all die. You don't tell your body what temperature to be. You don't tell your body when to sweat. You don't tell your food to move along your digestive tract. And if you think about everything that the autonomic nervous system does, just be grateful you have it, because otherwise you would never get anything done but thinking about all the different things that your body has to do. But the interesting thing about it, when these kids present with this cluster of symptoms that Dr. Miller was talking about, it might sound like they're completely unrelated. So you're not pooping for 2 weeks, plus you're having these weird sweating, freezing episodes, plus you're dizzy every time you stand up, and oddly enough, your hands and feet turn red. Like, it's the weirdest thing. And then you have to pee like 15 times a day. And you're thinking, they're not even related to each other. This makes zero sense. And so what the pediatricians end up doing is sending the kid to the urologist and sending the kid to the neurologist for the headache and sending the kid, to the gastroenterologist for the constipation, except it's all one thing. It's all the autonomic nervous system. So much so that recently we have actually established an autonomic rehabilitation program at Rainbow Bays and Children's Hospital. We did not invent it. We stole it whole cloth from Mount Sinai in New York. And I have no problem saying that. The physical therapist, he's got Dr. I can't think of his name right now, but he's brilliant. I called, I cornered him and made him have lunch with me one day at a conference, and he told me all about it. And then I made him give a lecture to my physical therapist, and we stole the program. So it was brilliant. So we really and truly believe that this is key, but it also makes it really, really hard to diagnose, because how do you test part of your body that's inside and is automatic? It's not something that we control. But we're starting to make a bit of progress in this realm, and slowly but surely we are getting there. But we think that is the key. So I know you guys are getting these slides, so we wanted to put some resources in here for you. Some longcovidkids.org, some stuff about chronic fatigue syndrome, which predates COVID-19. This is the problem. So in the United States, every hospital system has an adult COVID recovery clinic. They all do. There's 4 in this city that I can think of. Cleveland Clinic has one, University Hospitals has one, Metro has one, and the Mercy Health Center has one. So we have at least 4 adult COVID recovery clinics that I can think of off the top of my head in Cleveland. And we're not even a big resource city like New York or something. We have 4 of them. These are the pediatric centers. So this is one list off of one website. This is another list. There's some overlap. There's some not overlap. So that's the other problem, is because there's no central repository for pediatric long COVID. You can't go to just one place and find the list of clinics. You have to go to a couple different places. I have done everything I can to get our name and phone number and email address out there, but I have failed miserably. But we do get patients here because we're one of the bigger centers, and because I'm a loudmouth. There are patients flying here from Florida, from Texas. I mean, you can see places where there are no black dots. Texas Children's actually does have one. So what, Texas Children is in Houston, Dallas? I don't remember. Texas Children's does now have one that they recently opened. So they now have a little black dot there. But we have patients from Pennsylvania. We have patients from New York, all over the United States that fly here because we're one of the biggest and most well-known COVID recovery clinics. But we're not the only ones, thankfully, but there are very few of us, and most of us are very poorly funded. Most of the pediatric COVID recovery clinics, as is ours, are run on our administrative time. So for instance, I'm only supposed to do clinic on Tuesday and Thursday, but I do clinic on Friday during my administrative time so that I can fit in long COVID patients. Makes my boss super happy, because then I don't get any of my administrative work done, but whatever. And I have our care coordinator is borrowed. Our scheduler is borrowed, and that is how most pediatric COVID recovery clinics are being run, on a shoestring and with borrowed resources. And when you think about the impact, that's not good enough. And I kind of alluded to it already, parents having to take time off work, having to quit their jobs. That's immediate economic impact. And then think about the economic success of these kids, their career success, their economic success, their ability to contribute to society when we take away their teenage years because of chronic illness. And so the immediate impact is already being felt in the families. And the long-term impact to our country, to our state, to our economy is going to be vast. And I think we're in for it if we're not very, very careful. Like if we don't manage this now. So these were some ideas that we came up with for possible stories that could be done. I don't know how many times I've talked about pediatric long COVID being underserved, but let me say it again. We do know that children and young adults have unique needs. Adults, for instance, we don't have to deal with their schools. We don't have to deal with child protective services with adult long COVID. The kids are being dismissed left, right, and center. I can tell you one of the things that we see, again, it's the nervous system, right, is kids can temporarily or more long-term lose the ability to use one or more of their limbs. So I had a kid who lost the use of her left leg, so she was using crutches in order to get around school. So here she is trying desperately to stay in school with crutches, right, despite having dizziness, loss of appetite. She was losing weight. She was miserable. She had severe anxiety. Her school nurse told her to her face that she was faking, told the other teachers that she was faking it. The teacher started gossiping. Word got around to her classmates, and she was bullied incessantly until I called the school, chewed them all out, which they did not appreciate. And I think I'm now on their blacklist. But they at least stopped harassing her in school for using crutches and for having quote unquote long COVID, which was a made up diagnosis. The financial burden to these kids and these families are extreme. I mentioned, we literally have families flying up here from Florida because they are desperate. Parents are having to quit jobs. And so it's just the impact on these families is huge. And like I said, because it's difficult to identify, we're catching the high achieving kids, right? Because the high achieving kids going from an A+ student to a failure, that's obvious. We see the problem. Moreover, we believe the problem. The high achieving kids who are suddenly not achieving, the teachers are like, oh, how can we help you? When they talk to me, they're like, oh, Dr. Edwards, thank you for helping. We know she's not faking it because we know what a hard worker she is. I can tell you how many times I've heard those words. It makes me so angry. Because what about the kids who make C's and D's and F's? They get long COVID too. But do you think the teachers believe them when they say that they're having trouble doing their homework because they're so dizzy and they have brain fog? No, the teachers don't believe them. That they're just faking it, or they're just trying to find another excuse to get out of their schoolwork. And I can tell you how many teachers I have yelled at. Sorry, I get a little angry. And we keep going. How is long COVID driving awareness of chronic fatigue syndrome, which is a syndrome that existed before long COVID? We know that Epstein-Barr virus can cause chronic fatigue syndrome. How is long COVID affecting people with chronic Lyme? Chronic Lyme is another one that doctors used to say did not exist. If you got Lyme disease, you got better. Except you don't sometimes. And now that long COVID is around, doctors are finally like, oh, maybe chronic Lyme is a real thing. Maybe we should do something about that. And how is the population with chronic fatigue syndrome and with chronic Lyme, how are they handling suddenly now people are paying attention to them when all before they used to get ignored? The racial disparity that I think I've hammered that home enough, have I or not? Can I say it again? We're mostly seeing rich white people in our clinic. That is not okay. We have got to find these kids where they are, and we've got to help them.
And we've got to create sustainable mechanisms to treat them.
Right. Our current model where they're getting this $1 million workup and they have to eat whole real foods and they have to get very careful physical therapy and they have to be able to take frequent breaks throughout the day and they have to be able to rest. That is not going to work in our under-resourced populations. It's too hard. It takes 2 parents. It takes lots of money. It is not, we have got to come up with better treatment models. This is our clinic. You guys are welcome anytime. And that's where we're gonna end it.
I have to say, my first question is, I'm a little old, but are you taking any new patients?
We stop at 25, unfortunately.
I need to have y'all on my side. So start thinking about geriatric medicine. Let's get the microphone here. We'll start questioning with Mary.
Thank you both so much for this talk. So I have 4 children. I got COVID in March of 2020. A couple of the kids got COVID from me. And our oldest, it didn't go away. He was so much of what you described, the high achiever and whatnot. I got very lucky because we were in part of that first wave. The journalist in me and the mama bear, there were no answers. So I got him into a study that just got continued. So he still goes up to the Columbia University researchers. I'm getting seen by the Mount Sinai long COVID. And all of this going somewhere, I promise, for a question. But having watched all of this in real time, on one hand, the research is fascinating. I mean, they even studied his braces. He had braces, how long it stayed on the teeth. So much of what you described, the inflammatory, I mean, he had the arthritic symptoms, the raccoon rings around his eyes for so long, joint pain, migraines where he never had migraines, the light. It's fascinating watching. But what fascinates me is even with the resources of me being a journalist in New York City, the Mount Sinai Clinic won't see that you described, they don't see kids.
Right.
So I have to get everything anecdotally.
Yep.
The researchers give me information about how he's kind of tracking, but they said even there in like these silos. The Sinai researchers are great. I get anecdotal things from what you're describing. He has one gut doctor that talks about the foods. He has one neurologist that talks about the things. But everything is so siloed,
Yeah.
and I'm fascinated 3 years in. And I do have, I'm okay with raising my hand and asking questions, but there's not these resources.
Yes.
And I want to know from you, I know you're asking us as the media to talk about things, but I still don't understand when I talk to these super smart people. And the Sinai Clinic always apologizes that they don't see the kids. But what is it going to take? I mean, because now the other situation, you guys kind of alluded to it, when these kids are in adolescence, and we even see with, he's got a wonderful pediatrician, but some of the symptoms, brain fog, it can also be, it's a teenage boy, right?
Right.
He's exhausted, and he is an athlete, and he tries to compensate, but what you say, and he's wiped out in ways that I see our other kids aren't. And that could be associated with, he's going through maybe a growing streak. What are we doing? So my 2 questions are, what's going on with the CDC, the National Health? Why is there not more resources for the kids? 2, is there any incentivization? Because we're going to be in a crisis for a long COVID period. There aren't enough doctors. I mean, I see at the Mount Sinai. I mean, it's comical, the wait list. It's not comical.
Right.
The wait list, it's extreme. I mean, at one point it was like 18 months, right? So, and that's for adults. That's not for kids. So are they incentivizing in med school for people to study this? Is there more funding? And I guess the last question would be on a government level. I mean, is anyone starting to pay attention to this of looking into, addressing this situation, because it is out there. And from what I understand, even from him and his studies, I mean, it's what you said, it's a gajillion-dollar question. We don't know if these kids are going to outgrow this, right? Or if this is going to be a chronic condition.
So the federal government has funded, the NIH has funded about $54 million worth of research. A chunk of it went into the RECOVER study. We got some of that here. Most of the RECOVER study is adult focused. So very, very little to almost none of that money went to any kind of pediatric research. There are some randomized controlled trials that are going on right now. None of them include pediatric patients. Finally, so ARC, American Research and Quality and Health, ARQH, I'm not, AHRQ, thank you. We call it ARC. I can't remember what the letters stand for. Did fund, so they have released 9 grants and word on the street, per Rachel at the CDC, Dr. What's her bucket? The main person. Rochelle Walensky. Rumor has it that she has asked ARC to make sure one of the 9 grants that is currently being offered for long COVID research go to a pediatric center. But that's a rumor. We don't even have any proof that they're actually going to fund. We are submitting together. So we are unique not only being one of the only long COVID, but we're linked with our adult long COVID clinic at our hospital. We share education resources. We meet once a month to discuss interesting cases and science. And so we are asking for a grant to establish a true interconnected long COVID that can help with the adolescents as they transition to adult care, and to help increase the funding for our pediatric clinic, so that we can do some of these. But as far as we know, that's it. And that art grant is only going to fund 9 grants, and only one of which, rumor has it, might be earmarked for a kid, maybe.
Well, and it'll be $600,000 a year practical money,
Right.
too, which is
Over
not
5
that
years,
much, over 5
which is not
years.
much.
Right.
Yeah,
So
it's
we're
a half a drop in the bucket.
We were
Right.
fortunate to get, we had a very generous donation. It was a $100,000 donation from a private family who's suffering with long COVID. And we're going to do a retrospective chart review of our first now 220 or so patients and try to put that together into a publishable form to get some answers out there.
Yeah.
And what we really also want to promote is sort of looking at what we've done, try to figure out like what seems to be working for people and get some recommendations out there. Because that's one of the things that I see is that there's nothing formal
Right.
about how do you treat these kids.
Right.
And I think what we found is there really are things you can do that can make a massive difference. Some of them are like clean up the diet, get the sleep organized, and practice pacing. Like, the diet costs something, sort of, depending on how you do it. But the others don't cost you anything. And if we can get at least the doctors to be online with that and the families to try that on their own, that'll, I think.
And the autonomic rehab is actually pretty easy as well. There's a lot of autonomic rehab that already exists in the world, in the POTS world, the postural orthostatic tachycardic syndrome world. That rehab is typically linked with physical activity, which we discourage in long COVID. But the techniques are actually already there, the sympathetic and the parasympathetic alternative stimulation. And so it's not that hard to step that down and take the physical activity out of that rehabilitation. So some of the tools are there. It's just getting the information out there that people need to be doing this for these kids is the main thing. And, I'm shouting as loud as I can.
It's one of the
listening.
most frustrating things I find about health research in general. One of our speakers yesterday talked about childhood obesity and the fact that the new guidelines from the American Academy of Pediatrics encourage medical intervention, surgery in a way that they hadn't before. And so now with this topic, it seems that the more research advances, the more the people who need it most are left behind.
Absolutely. And especially when it comes to kids. And I think one of the frustrating things, so when we look at, for instance, at vaccine research, so think about the COVID vaccine, when you look at medication research, what group is always left out of the first study? Kids. They always leave the kids out. Always. Even if it's a pediatric vaccine. I mean, when they did the meningococcal vaccine, they started with adults, but it's kids who are dying of meningococcus. Like, are you kidding me? I almost slipped a swear word in there. I'm very sorry. And now with COVID, I mean, if you look at the drugs that they're currently studying for treatment of long COVID, things like IVIG, things like metformin, which blocks sugar uptake, so it reduces gut inflammation. There's a reason there. I know it's a diabetic drug, but there's a reason there. These are drugs that are already approved by the FDA. And in fact, many of them are already being used in children in various circumstances. So there's no reason to leave kids out of these drug trials for long COVID, and yet they are. They are cutting the age off at 18. Because there's no, right. And there's no,
to be privately
right.
funded or governmentally funded.
It's going to need,
the companies aren't
going to do it.
We can take a couple more questions here and then.
Hi, I'm Maddie Alexander. I'm with Politico. I have a question sort of about like the autonomic function post-exertional malaise. Full disclosure, I have POTS. So, a lot of the like initial treatment for that is that graduated exercise, doing things like recumbent exercise, the routine protocol, and for like ME/CFS, that's not recommended at all.
Right,
And
absolutely.
So, there are a lot of physicians who, at least I'll see people in like support groups say, my doctor is kind of just out of shapes, sort of a thing.
Yep.
How do you combat the like professional knowledge where people think, doctors are saying like, well, it's just deconditioning, right? You have to work back up, when that may actually make your condition so much worse. And that seems to be sort of happening on a really large scale across the country?
Not even just across the country, in my own hospital. So we had established a relationship with a couple of cardiologists within our group who were seeing all of our long COVID patients, and they were really on board with the idea of not using the Levine or modified Levine for our POTS patients because of that post-exertional malaise, that chronic fatigue syndrome component. But they recently, both of them unfortunately, went to different institutions. And the new cardiologist, who's currently kind of placeholding until we can get a new cardiologist, literally just told one of my sickest patients to go to physical therapy and exercise for 30 minutes a day. And so the kid tried. She tried and then fainted. And I literally had to email him a very sternly worded email, like, if you recommend one of my patients exercise again, I will walk over to your office and smack you upside your head. Like, if you're not sure what to recommend, please email me, because if I need to go get board certified in cardiology and do it myself, I will, because I'm just not going to tolerate this. So it's not around the country, it's everywhere. And we have a long COVID clinic, and I have doctors in my hospital who don't treat it properly.
Yeah, we've met with the emergency room department, we've met with the psychiatry department, the psychology department, physical therapy, a lot of different groups in cardiology, and we get some great people going and they get educated, but the problem is if that person leaves, the next person doesn't know. So one of the things we'd like to do is establish sort of teaching modules that can exist in perpetuity and preferably for free on the internet so that people can actually view those, and maybe patients can send it to their doctors if their doctors are willing to watch them, so they don't make some of those sort of, almost like elementary level mistakes in terms of the management of people with dysautonomia.
Let's go to Piper now.
Piper Hutchinson, Louisiana Illuminator in Baton Rouge. You spoke a little bit about what you're hearing from teachers, but as teens go on to college, what sort of feedback are you getting, like in terms of accommodations, how they're being treated, as they grow up a little bit?
It's very variable.
Mm-hmm.
Some of our colleges, and I think anybody with disabilities will say this, some colleges are fantastic and are really willing to work through their Office of Disabilities with these kids. And some colleges are like, dude, you're an adult now, you need to manage your stuff. And so I've got kids who are now doing part-time college because that's all they can manage and their college isn't willing to make accommodations. And I've got kids who are thriving in college despite their long COVID because their colleges are willing to make the necessarily accommodations. What we need is better guidance from the federal government. That, because it's one thing for this random doctor in Ohio to be like, this is what you guys should all do. Please make me the god of long COVID and I will fix it. But I can't, there's only so much I can do and so much that Dr. Miller can do. And so we need better federal guidance. But if you look, we know that President Biden is disbanding the COVID task force. I want to literally flip my shit. Sorry, I can't help it.
We can edit.
I'm very passionate. I'm very passionate about this. One time CNN didn't edit. And,
Oh, really?
Yeah. Oops. Be very careful when you interview me. And if you look at the WHO, if you look at the American Academies of Science, I literally had to approach the WHO and say, you know what, you're including me in your you are doing this. And even that long COVID conference that Dr. Miller talked about earlier that was in DC last year, I emailed them and said, you will have a pediatric panel. And they said, great, you're in charge of it now. Otherwise, pediatrics wouldn't have even been represented. And so, it's a problem.
And what we're trying to do also is work with families to give them an idea of the things they should be asking for too. Like if you have a schedule, don't schedule back-to-back classes for 6 hours a day. Make sure you have breaks between your classes. Make sure you don't start at 7 a.m. or 8 a.m. Start at 10 a.m. if you can. So we try to also help coach the families in terms of how do they navigate the school. And then also where do you look for assistance like the Office of Disability and what do you ask for? And it is an ADA protected condition theoretically, right? If you have multiple systems involved that impair your daily functioning in 2 or more realms or something like that.
Well, they specifically list the Biden administration did specifically list long COVID
As an ADA
protected disability, but then you have to get the diagnosis of it and you have to get people to actually not break the ADA.
I had a family show up the other day and they're like, we've been to 6 different doctors and they all agree we have long COVID, but none of them make the diagnosis. How do we get that diagnosis?
Right.
And it's like, they just have to put it in the chart. All they have to do is make the diagnosis.
Right.
And doctors are uncomfortable for some reason making that diagnosis.
And then you ask, you have patients who ask for disability placards, for instance, so that the patients don't have to walk as far. It's very easy to do, but a lot of pediatricians especially are very uncomfortable with disability placards. We don't do it a lot, because most kids are not disabled. And so a lot of pediatricians are like, I don't know if I can do that.
Mm-hmm.
And so that really puts the kids at a disadvantage because they need to be parking closer to the schools and the stores and things like that because most of these kids can barely walk. And so just little things like that.
Are there any more questions? We can probably take one more if there is. If not, what I wanted to ask is, you gave us some great story ideas
Right.
up there, but one thing I want you to keep in mind is that they're going to have to go back to editors
Mhm.
and in 15 minutes, try to get them to understand why this is a story. And I'd like you, if you could wind up by helping them really grasp this issue of the cost to society when we allow the research to advance, but yet still leave people behind. Is there one sort of parting thought you can use?
In the state of Ohio, based on best estimates, there are somewhere between 30 and 70,000 children with long COVID. In university hospitals, Rainbow Babies and Children's Hospital, there are 2,000 kids who have the ICD-10 code for long COVID in their chart. Dr. Miller and I have seen 200 kids in our clinic, and we're one of the biggest clinics.
Right.
That right there.
Yeah,
to me.
we're leaving behind a massive population of young people, who will be on disability, who will have disruptions to schooling and to work, whose family lives are disrupted, for years to come because we haven't adequately addressed this issue and we haven't paid attention to them. And we know it's happening all around us. We can see it. The numbers tell us, and we're not doing it.
Well,
I'm Buddy Beach, Texas Public Radio. The attitude of kids since the beginning is, hit many circles and let them get sick.
Right.
And especially now with the emergency ending this week, the public health emergency ending this week. My daughter wore a mask until about a month ago because from the beginning we knew that multi-system inflammatory syndrome in children was a problem. So, I'm not playing. But she wore a mask for years. Most kids don't. And should they, especially considering the risk of repeated infection, do you think that increases the risk of long COVID in children? And if so, how do we protect them against that in a world that's essentially moved on, but COVID is still killing 1,000 people a week?
So there's a couple of interesting things that we see in kids. One is that, yes, repeated infection. Like we hear the story where, okay, I got COVID and then I'm okay. And then I get COVID and I'm less okay. And then I get COVID and boy, I am not okay. So we absolutely see that pattern that getting COVID again and again and again is not protective against long COVID. You can get long COVID after any infection. The other interesting phenomenon that we see in children is they get COVID and they get better. And then they get, 3 months later, they get strep throat or they get the flu. And those things do not have post-infectious syndromes. I've been doing infectious disease for many, many years. They are not associated with post-infectious syndromes. And then boom, the dizziness comes, the brain fog comes. So it's after an infection that had nothing to do with post-infectious syndromes, but it was primed by COVID 3 months prior. And now they're getting long strep, I guess you would call it, or long influenza. And so yes, repeated infections is a problem. And that is why nobody in my family has yet gotten COVID and why we still wear N95 masks when we're out as a family. And why my kids still don't go to Target, Walmart, the grocery store with me. I go by myself with a mask on. I wash my hands when I get home because my kids are not getting sick. I'm not doing it. Like we're not having that in my house. I absolutely refuse. And it's interesting to ask about masking because that is meant to be a temporary solution, but the governments never did the permanent solution, which just drives me crazy. Why have all of the schools not been retrofitted with better ventilation to improve kids' ability to attend without catching every stinking illness that goes around? Why are kids getting croup right now? My daughter has croup right now. Why? Because the schools never had the infrastructure improvement that they should have had during the pandemic so that kids wouldn't get sick and have to miss. I mean, forget COVID. Why are kids missing 3 or 4 days from croup? Why are kids missing school from RSV? They shouldn't be catching these illnesses in schools because the schools should be built in such a way that you don't get sick. And we know it's possible because the director of infection control for Rainbow Babies and Children's Hospital is sitting right there and the kids don't get sick in the hospital. So it is possible to build ventilation systems that don't get you sick, but the schools never did it. So yes, we should be masking, but no, we shouldn't be masking because the schools should have fixed the problem, and they never did.
And people need to get vaccinated,
And people need to get vaccinated.
you know.
Don't even
There
get me
is a
started on the
protective
vaccination. There is a very clear protective effect from the vaccine. It does reduce your risk of long COVID.
Wow. This has been an incredible conversation, incredibly important conversation. And I'm hoping that you all will take advantage of now having access to two of the leading researchers in the country on the issue of long COVID in children. So I'd like to take this opportunity to thank Dr. Miller and Edwards for joining us today.
Thank you very much.
Have a nice-
Thank you so much.